Good afternoon. Thank you for joining us for Astarte Medical's webinar presented by Dr. Gautham, Achieving Nutritional Excellence, Improving the Quality, Safety, and Value of NICU Nutrition. I'm Tammy Jansen, co-founder and CFO of Astarte Medical. For those of you who don't know us, Astarte Medical is a precision nutrition company providing digital solutions to support nutrition and feeding practices for preterm infants in the NICU. We're hosting a series of educational webinars this year, all focused on the growth and development of preterm infants and the importance of feeding, nutrition, and gut health. I'm thrilled to share our incredible lineup of upcoming speakers with you. You can find the details for all of our webinars, both past and future, on our website. Please mark your calendars and join us for our next webinar on October 27th for a presentation by Dr. Mark Mazer on the challenges of preterm infant formula development. Dr. Mazer has a PhD in nutritional biochemistry. He retired as Director of Clinical Nutrition Research at Abbott Nutrition after spending 16 years conducting infant nutrition research. So we're excited about our next webinar. So let's get started. We'll have plenty of time for questions at the end. Please feel free to post your questions throughout the presentation in the chat box located on the right side of your screen. We'll compile the questions and get to as many as we can. I'm pleased to introduce our esteemed presenter and expert in the field of neonatal feeding and nutrition. Dr. Gautham is a professor of pediatrics at Baylor College of Medicine and a neonatologist at Texas Children's Hospital. He previously served as section head and service chief of neonatology at Texas Children's Hospital. He's a deputy editor of the Joint Commission Journal on Quality and Safety and a senior editor for the Neonatal Review Group of the Cochrane Collaboration. I'll now turn it over to you, Dr. Gautham.
Thank you, Tammy. Let me just pull up my slides. Can you see my title slide?
Yes, looks great.
Good afternoon, everybody. Thank you for joining this webinar. Thank you to Astarte Medical for organizing these webinars. And what I plan to do is give a talk for about 40 minutes or so, and then we can have question and answers and discussion. And I really hope that all of you will participate in a vigorous Q&A and discussion. I don't have any conflicts of interest to disclose. I will be receiving an honorarium from Astarte for this talk. And I would like to start by acknowledging my teachers and mentors over the years, from whom I have learned so much, both about nutrition and quality and safety and value and evidence-based medicine. I'm really grateful to all my mentors and teachers, and there are many more who are not listed on these slides. Here's what I want to talk about today. I want to spend a lot of time talking about general concepts of quality, describe quality problems in healthcare in general and nutrition in particular. I want to talk about quality improvement, what are the key concepts, frameworks, and methods, and then give you some examples of quality improvement projects that have addressed neonatal nutritional topics. Let us start by understanding some general concepts and terminology and definitions of the quality of healthcare. There are three key terms for us to understand: quality, safety, and value. In the 1990s, the Institute of Medicine started publishing a series of articles on the quality of healthcare, and they defined quality as the degree to which health services for individuals and populations increase the likelihood of good outcomes for these individuals and populations and are consistent with the current state of scientific knowledge. Later on, in 2001, the Institute of Medicine started publishing a series of reports called the Quality Chasm reports. The first one was just called Crossing the Quality Chasm. And in that, they pointed out that there are 6 important domains of quality: safety, timeliness, effectiveness, efficiency, equity, and patient-centered care. To these, I think I would like to add my personal 2 additional domains. One is consistency, And variation from provider to provider and attending to attending is a big problem in the neonatal unit. And I think consistency is another aspect of quality we should aim for. And then avoiding waste has become an important area for study and implementation in the last 2 decades. Another way of understanding quality and the framework for quality is to understand what Dr. Don Abadian from Ann Arbor in Michigan described many years ago. He said quality can be thought of in terms of structure, process, and outcomes. And to that, I think we should add another important domain, and that is of pattern, also known as culture. Structure refers to the resources, the personnel, the equipment, the space, the availability of subspecialists and other resources in your organization. Process is the sequence of steps about how work is actually done. And outcomes are the ultimate results of the process. So things like mortality, necrotizing enterocolitis, parent satisfaction, and so on. But unless you have the right culture in your organization, you will not achieve adequate structure, process, and outcomes. So that's an important point to remember. The second report that the Institute of Medicine published was on medical errors and patient safety. Patient safety was defined in that report as freedom from accidental injury, and it involves the establishment of systems to decrease errors and intercepting them when they occur. The most recent term that a lot of institutions and organizations are using is value, and value in a simple format is defined as quality divided by cost, because you want the highest quality outcomes for patients and families for the lowest amount of expenditure. And that is the definition of an efficient healthcare system. So why did the Institute of Medicine publish all those reports, and why has quality and safety become such an important topic of a study and implementation? It's because for a long time, doctors were trusted and hospitals were trusted. The public said, you guys are specialists. We think you know what you're doing and we trust you. But in the late 80s and early 90s, a series of publications revealed that there were huge quality problems in the US healthcare system. And these quality problems could be divided into underuse, which is treatments that were proven to be effective in scientific research were not being applied to improve the health of patients. Overuse, a lot of diagnostic tests and treatments were being used without any justification or rationale, and frankly were being wasted. And then misuse, which is the improper application of a treatment that includes medical errors. There are two famous studies, both neither of which is in neonatal intensive care, which showed that on average, adults and children receive about 50%, receive optimal care about 50% of the time. So Miglin and colleagues did a well-known study where they reviewed patients, adult patients in outpatient offices, and Dr. Mangione-Smith performed the same type of study, and 54% of the subjects in Miglin study and 46% of the subjects in Mangione-Smith study received optimal care. The rest had poor quality care. No such study has been done in neonatal intensive care, but I bet you if you did the same kind of study, we would find the same kind of results. And it is studies like this that led to the report called Crossing the Quality Chasm. And they intentionally chose the word chasm because they said between the gap that between the care that Americans deserve and the care that they actually get, there is not just a gap, but a chasm. So I would invite you to think, is there a quality chasm in neonatal intensive care, especially in the field of nutrition? I think there is, and I think there is a lot of work to be done in this field. I talked a little bit about waste, and experts have described that there are 8 different kinds of waste in healthcare. Unnecessary motion, where the healthcare provider is moving back and forth to get supplies or organize, equipment, delays in care, conveyance problems, correction of things that were defective but could have been done right in the first place, excessive inventory or inadequate inventory, as we saw during the COVID-19 pandemic with lack of PPEs, overproduction, overprocessing, and knowledge disconnection, where the frontline worker does not have access to the latest guidelines and protocols and policies about how the work has to be done. So all these just increase the effort we put into healthcare and decrease the output, so which is a form of waste. And if you look at the waste in terms of dollars, in 2011, one estimate was that $910 billion were wasted in the US healthcare system due to failures of healthcare delivery, failures of care coordination, overtreatment, administrative complexity, pricing failures, and fraud and abuse. So this is a huge area for us to work in, and all of us have an ethical responsibility to reduce waste and contribute to decreasing the runaway healthcare costs of the US healthcare system. And there is an active group working on overdiagnosis and overtreatment. And in fact, there's an annual conference at Dartmouth on overdiagnosis, where the world's experts on overdiagnosis converge and talk about how to ensure that clinicians are not ordering needless tests and needless treatments. And of course, the pharma industry and the device industry kind of drives overuse of tests and treatments with the incentive of profit. And there are a lot of experts pointing out this connection as well. The American Board of Internal Medicine Foundation a few years ago launched a program called Choosing Wisely to address this concept of overuse and overdiagnosis and overtreatment. And they challenged every specialty society to come up with a list of 5 things that their specialists could stop doing safely, which would not decrease the quality of patient care and which would avoid unnecessary costs. The list for neonatology is shown in this slide. Dr. Ho and colleagues from the Beth Israel Deaconess Hospital, working with Dr. Zupancic and Dr. Persley and other experts, came up through a survey methodology, a list of 5 interventions that neonatology professionals should stop doing, because essentially we're wasting money and time and effort when we do these things and not contributing to improving patient outcomes. I won't read through the slide, but you can see that anti-reflux medications for the treatment of GE reflux disease top the list. And there are still many NICUs where there is a lot of use of these medications putatively for treatment of GE reflux disease. This is the report that I mentioned that emphasized patient safety, and this was the second in the series. And in this book, they reported that medical errors kill more patients every year in the US than motor vehicle accidents, breast cancer, and AIDS. Yet these other 3 causes of death get so much attention and so much funding, and patient safety does not. So this report really kick-started the patient safety movement, and a lot of my work in quality and safety has been in the field of patient safety and most recently in diagnostic errors. I mentioned the need to add some domains of quality, and one of them was consistency, that addresses how to decrease variation between clinicians. We all know, working in the NICU, that there is a lot of variation in clinical practice from attending to attending, nurse practitioner to nurse practitioner, and nurse to nurse. This is higher for some interventions than others, and is a source of frustration to staff and parents and trainees. This decreases the quality of care and potentially increases the costs and waste of care. And if you do what I call a color grid, where you ask different attendings who are listed in column 1 about their preferences for, say, prophylactic indomethacin, or when they want to stop apnea monitoring in a baby, and when they want to declare the apnea countdown as completed, you will get a multicolored map like this, where for some practices depicted in green here, there is a lot of concordance between different attendings. And for some practices, there is a lot of difference of opinion and strong feelings about the practice itself. So harmonizing the practice and making sure that there is consensus and consistency of practice has been an important target of many quality improvement interventions. And I will show you some data later on about the potential benefits of standardized nutrition protocols published by Jasani and Patole from Australia. So those were some general comments about quality and the quality problems and the need to address quality. But if you just like hone in on nutrition right now, what are the current quality problems that we clinicians encounter in the NICU? The top one, of course, is an inadequate supply of mother's own breast milk. I still think that there are many opportunities to increase mother's own milk, which we are not availing of. Of course, in the past 6 months with COVID and with the major national incidents like the death of George Floyd and so on, racial disparities in healthcare have become very important to discuss, and we can no longer ignore disparities in healthcare. So we all know from published literature that there are huge disparities in the usage and production of breast milk across patients of different ethnicities and races. And that's an important quality target, and frankly, one that has not been proactively addressed by many people in this field. Suboptimal nutritional intakes are also very common. This leads to poor growth and extrauterine growth restriction. Delayed achievement of nutritional milestones is common. There are ongoing errors in nutrition delivery. Necrotizing enterocolitis still plagues us, and the rate of NEC in some NICUs is 3 or 4 times higher than that of other NICUs. And then we still need to focus on improving long-term outcomes related to nutrition and eliminate errors in nutrition delivery. We published a paper back in 2004, and I've been reviewing the literature on this topic periodically. And here are some errors related to neonatal nutrition that we should be aware of and address. Administration of the wrong breast milk to an infant, so wrong mother's breast milk, still happens. It's infrequent, but it's not gone away completely. Administration of formula to a baby whose mother requested exclusive breast milk. Placement of a gavage tube inadvertently into the trachea and infusion of feeds into the lungs. This has been reported, and I have seen cases of this myself. Gastric perforation or esophageal perforation from a feeding tube continues to happen. TPN composition errors, TPN infusion rate errors, where the pump is misprogrammed and the baby gets an overdose of intralipid, or the rate of lipid and the TPN solutions is interchanged and the baby gets overdosed. And then occasionally you hear about milk being infused intravenously in one unit or the other. I think this happens about once or twice a year across the country. And these are some errors related to neonatal nutrition. What about waste in nutrition? Here are 2 examples, and I think all of you can come up with plenty more examples if you think. There was one patient that I was caring for where we ordered peripheral TPN. A PICC line was placed and a central TPN ordered. And the peripheral TPN, which had previously been ordered, because we didn't plan well for the PICC placement and central TPN, had to be wasted. There was another infant who had a staph sepsis. Treatment was continued with the UVC in place. Blood cultures cleared. A PICC was placed. The new TPN was mistakenly connected to the umbilical venous catheter, which was about to be removed. And because it was connected to a catheter that was coming out and was not going to be used, that TPN had to be discarded. So there are hundreds of examples like this every day in our units. And eliminating these kind of waste is an important quality improvement goal. Let us look now at some data from the Vermont Oxford network that shows the opportunities to improve quality. This is a report of babies 501 to 1500 grams born in 2019 and their status at home discharge. You can see that if you look at all infants, only 58% of infants had any human milk at the time of discharge. And remember, this is not complete human milk feeds. Even if they received one feed out of 8 with human milk, that would be counted as a yes for this variable. So 58% was the amount, the percentage of babies receiving any human milk in the 24 hours before discharge. And if you look at babies' weights and head circumferences, 31% had a discharge weight less than third percentile, 54% had a discharge weight less than 10th percentile, 16% had a head circumference less than the third percentile, and 33% had a head circumference less than the 10th percentile at discharge. And if you look at these data going back 7 years, you see that there has not been any significant improvement, and the numbers continue to show that there's a huge opportunity for improvement in the usage of human milk, in discharge weight, and the head circumference at discharge. So the numbers are pretty similar to what I just showed you in the previous slide. And if you look at variation between unit to unit, if you look at that vertical bar that is labeled NEC, this represents, the dot represents the median and the bar represents the interquartile range going from 25th to 75th percentile. You can see that in 25% of units, the NEC rate was 0. And in 25% of units, the NEC rate was much higher. I don't have the anchoring number there, but it's probably around 7 or 8% or higher in 25% of the units. So again, this illustrates not only a huge variation in practice, but there is a huge variation in outcomes of outcomes related to nutrition. And similarly, every outcome shows a huge variation, showing that some units are doing better than others in achieving good outcomes, and other units have a lot of room to go in making improvements. So how do you start monitoring and improving quality? I remember back in the 90s, my mentor, Dr. Horvath, was generating all these reports from the Vermont Oxford network and giving them to the member units. And people started calling him up and saying, don't just tell us how badly we're doing with outcomes and processes, tell us how to get better. And that's when the Vermont Oxford network got into quality improvement. And I had a chance to work with them and learn from them, for which I'm very grateful. So the first step for any NICU is to develop a set of ideal data habits. You have to measure and monitor key quality indicators in your practice, and you have to select the right number of quality indicators. Don't go overboard, and be parsimonious in the portfolio of indicators that you select. You have to use data provided by the administration of the hospital and by external agencies like the Vermont Oxford Network to supplement your own additional data quality monitoring in the unit. You have to compare your performance against standards and with other units across the country. So based on monitoring these quality metrics, you should identify the priorities and the areas for improvement in your own NICU. And then you should launch quality improvement projects to improve your practice in these areas. And for these projects, you might have to collect new data metrics related to the project, in addition to the background dashboard of quality indicators. When you're collecting quality indicators, it's important to collect a holistic set of them so that you're not merely measuring clinical or costs, but taking the concept of the balanced scorecard for organizations. Batalden, Nelson, and colleagues came up with this concept of clinical value compass. And they said the metrics that you track for quality assessment have to be clinical, they have to be functional, they have to involve parent satisfaction, and they have to involve costs, both direct and indirect medical. So when you're collecting data, make sure you're collecting data from different domains and not just clinical indicators or Press Ganey scores and so on. Ultimately, the goal for your quality metrics that you monitor routinely is to develop a dashboard where you're keeping your eye on a few key vital signs for your unit or a few key vital signs for your car. And this will tell you how your unit is performing and whether you're on track for the various quality indicators that you have chosen to monitor. All of us could develop a nutrition dashboard because nutrition is a data-rich field. Every day we're collecting a lot of numbers related to nutrition in every baby. And unfortunately, the data are kind of disorganized and they reside in different locations. They live on clipboards, they live in the electronic medical record, they live in spreadsheets that dietitians fill out, or they live in the notes of attending physician. And there is a need to streamline and integrate the data collection systems across all these disparate repositories so that you can analyze the data meaningfully, keep track of your important metrics, and have a good visual graphic display of key data. And that is the emerging field of data science and data analytics. But I think we can do a lot better in all our units, including our own, with the monitoring and tracking nutrition metrics. So once you have a dashboard of nutrition metrics, you have to select priorities for quality improvement. And you can either look at things that are out of range in your nutritional dashboard, or you can respond to pressures from external monitoring where somebody is saying, hey, why is your NEC rate so high? Or if you have individual cases that raise concerns about the quality of care, you may choose to work on those projects. So all these pathways lead you to identify a quality problem or gap that should stimulate a desire in your unit leaders to improve, and that should lead to a quality improvement project being launched. When you do quality improvement, there are many terminologies and methods, and I'm sure all of you are familiar with these methods and terminologies. And it's important not to get bogged down into one sort of framework or the other. So you'll hear terms like lean, improvement science, implementation science, healthcare delivery science, operations research, performance improvement, translational research, and so on. But really, quality improvement at its core is an approach where you make intentional change in a methodical, systematic way. And in a way, it is the scientific method in action in your unit, with your unit serving as the lab for the science. Why should we indulge in quality improvement? It seems like a redundant question, but obviously the most important reason is it improves patient outcomes. It decreases waste and costs, just like I described in a few slides earlier. In other words, it increases value. It provides a competitive advantage, especially in cities where there are a lot of hospitals and institutions competing for patients. If you have good quality metrics, and especially if they're linked to public rankings or rankings in the media, it will enhance the image and reputation of your unit and will attract more patients. It satisfies regulators and accreditors who are really keenly focused on quality now. You can avoid payment penalties and medical legal problems and media attention. And also you can avoid patients posting angry comments on social media now. And of course, the ACGME and the Board of Pediatrics want us all to be constantly engaged in quality improvement activities, without which you cannot even get maintenance of certification now. Other strong benefits of quality improvement are that if you have good outcomes, you will see a highly improved morale amongst your staff. It improves efficiency and satisfaction, so you can get through your shift and go home sooner at the end of the day, feeling better that you did a good day's work. Ultimately, quality is the right thing to do. And it's an essential leadership skill for nurse leaders and physician leaders and respiratory leaders, dietitian leaders who work in the NICU. For those of us in academics, work in the field of quality, safety, and value can lead to publication and scholarly products. But to me, one of the essential reasons why we should all be constantly involved in quality improvement is a quote from my mentor, Paul Batalden, who wrote, "Everyone in healthcare really has two jobs when they come to work every day, to do their work and to improve it." So we should all see quality improvement as part of our job description, that we're not just dropping in and completing our shift, you doing the same old things, but we're always looking for an opportunity to do things better, to improve patient care, improve efficiency, and improve the condition of the families of the patients that we take care of. So once you decide to launch a quality improvement project, there are some key aspects. You need good leadership support and resources, otherwise the project will fail. You have to select the project carefully and focus on sustainability from the beginning. I cannot tell you the number of quality improvement projects that I have seen and participated in that just fizzled out after some time. And there is a graveyard somewhere of quality improvement projects that died halfway during their life cycle and were never resurrected. And so sustainability is very, very important for quality improvement projects. You have to form a multidisciplinary team, teach the team good teamwork skills, including meeting skills, and as far as possible, try to involve the family or a family member as part of the team. Then data and measurement are really important for quality improvement. And the data you collect should also attempt to track unintended consequences which can result from quality improvement projects. Then your team should take a structured, methodical approach and really use the concepts of project management, where the work is broken down into discrete chunks. There are tasks assigned to discrete people, and there are timelines. And you keep good track of the project so that you don't fall behind schedule and you don't fizzle out. Then finally, it's important to pay attention to the psychology of any change that you introduce into your unit or organization. So there's a lot of literature on change management by people like Carter and other experts. So applying those concepts of change and explicitly managing change is very important in quality improvement. In terms of the framework that you use for quality improvement, I think the best and simplest one is the model for improvement, which all of us should be aware of by this time. You specify a clear aim. You select metrics that will tell you whether you're achieving your aim or not. Then carefully select changes. But these are hypotheses when you select them. And you have to do some rapid tests of change in plan, do, study, act cycles to see if these changes actually result in the required improvement, the desired improvement, and then refine your interventions as you go along with the project. And there are many tools that we don't have time to go into. This is a fishbone diagram, which is a kind of diagnostic tool that will help you identify the causal and contributory factors that are causing the problem that you're trying to fix. And then there is a key driver diagram. In this slide, I've illustrated a key driver diagram for weight loss in adults, not for NICU babies. There are primary drivers and secondary drivers. And really, the two primary drivers are decreased caloric intake and increased caloric expenditure. And of course, there are cultural and social factors that lead to behavior that either enhances or prevents weight loss. And there are a lot of marketing and media influences as well. So by organizing the activities that will ultimately lead to your desired aim into a logical structure and grouping of natural or similar activities, you can really organize your project and your interventions and assign tasks to different team members so that there is good rational work distribution of the activities. So when you go back to this model for improvement, if you look at that question, what change can we make that will result in improvement? It is very common nowadays for teams to start off with a set of interventions that have a high probability of achieving the desired aim. And these sets of interventions have been called different names, potentially better practices, bundles, change concepts, key clinical activities, toolkits, or a starter kit, or a QI kit, or change packages. So different projects will use different terms, but they essentially refer to the set of interventions that you want to test in PDSA cycles. Another very important concept about quality improvement came from Batalden and Davidoff in a seminal paper published in 2007. They point out that in order to achieve measured performance improvement, you have to take generalizable scientific evidence. You have to know the context where that evidence is being applied, and you have to modify it to suit the local context. And then you have to execute the desired plan, you have to implement, and you have to carefully manage the change. And you have to have a reflexive pattern of adapting your interventions based on how the system responds. And ultimately, it is all these things that will lead to measured performance improvement. So I have found this Batalden equation a very powerful conceptual model to apply in my work in quality improvement. And Batalden also said, every system is perfectly designed to get the results it gets. So ultimately, it's all about system redesign to get the results that you want. So if you had to do a system redesign in your NICU, how would it look and what is a framework that you can use? I'm offering you a framework for you to consider. You should start going off the Batalden-Davidoff formula with the evidence and try to create unit-based guidelines that achieve some consistency, but also allow some room for customization for each patient, which constitute exceptions to the guideline. And then these evidence-based guidelines have to be implemented in a consistent way without any errors and with a high degree of compliance to guidelines through systematic quality improvement measures, quality improvement projects. You have to have implementation measures which tell you how well the guidelines are being adhered to and what the error rates are. Then you have to have process measures which actually capture the nutritional delivery of nutrients and the process by which nutrition is delivered and growth and outcomes are monitored. And these could be something like initiation of TPN, initiation of enteral feeds, attainment of significant nutritional milestones, the type of nutrition used, and the error rates of nutrition. And then you should consider measuring outcomes, which could be related to growth, they could be related to feeding, and family satisfaction with the whole process of nutrition, including lactation and breast milk production. Now, this whole framework is encapsulated in a bigger box called structure, resources, and governance. And there has to be an organized program where you periodically review the elements of this framework. You allocate adequate resources, including personnel, to quality improvement projects and activities. And there has to be some governance so that there are clear expectations and reporting systems and supporting systems for people who are doing the work. So let's move now into the last portion of the talk, which consists of examples of quality improvement in neonatal nutrition. And there is a link on this slide, which is a public link on PubMed. I have collected over 200 articles on quality improvement in neonatal nutrition. And if you just go to that link, you can review all those 200 plus articles and look at the variety of quality improvement activities that have been published. And I'm sure there are at least several hundred quality improvement projects that have not been published. but this link will give you the published articles. Here's an example from the King's Daughters Hospital in Norfolk, Virginia by Mangum and colleagues. They noticed that there was a problem with the timing of starting TPN. It was highly variable. And also the interval between initiation of the TPN and the blood draw next morning for labs, which the rounding team would use to make decisions in rounds, was highly variable. So they wanted to make sure that TPN was hung consistently around 4 p.m. and that there was an adequate and long period of time between the TPN being hung and the labs being drawn the next day. And through a series of quality improvement interventions based on lean concepts, they were able to significantly increase the average infusion time of TPN as shown in this control chart, and they sustained it for a long time. Similarly, the compliance with initiating infusion of TPN by 1600 every day increased significantly through the life of the project. And so they were able to achieve their aims and maintain the success for a long period of time. This was a really nicely done and well described article on quality improvement. Not only did they change their process measures of TPN hanging and TPN duration, but in babies between 1,000 to 1,500 grams, there was a statistically significant decrease in average length of stay in babies who received TPN. So there were some significant cost benefits by reducing length of stay, and patient outcomes are also better because these babies were going home sooner. Here's another project from Nationwide Children's where they developed a structured approach of cue-based feedings in babies with BPD. They came up with some guidelines and did education to all the providers on when to introduce cue-based feedings and how to advance cue-based feedings. And with that, they were able to show significant improvement in the number of days and the weight velocity, grams per kilo per day, in babies with BPD. Another project from the same institution by Sudarshan Jadcherla and colleagues, again a very nicely done and nicely described educational product, QI project. In this project, they aim to prevent feeding failure by 38 weeks post-menstrual age and decrease the length of stay from 96 days to 86 days over a 12-month period. And they laid out their key drivers, which included education, multidisciplinary collaboration, again, consistent guidelines, a simplified feeding program, and data collection system. And over the life of the project, they were able to improve the percentage of babies in whom enteral feeds were started on time to by 81%. And they were also able to increase the percentage of babies in whom oral feeds were started at 120 ml per kilo per day. Oral feeds were achieved at 120 ml per kilo per day in the intervention group. The post-menstrual age at the time of the first oral feeds also decreased. And so did the post-menstrual age at the time of discharge, again showing that good nutritional quality improvement projects can decrease length of stay and decrease costs and really improve patient outcomes. It's just not just process measures. And in this P chart, they showed a clear decrease in the length of stay over the life of the period. So they really achieved their aims and decreased the length of stay. Next, I want to talk a little bit about quality improvement collaboratives. Until now, I showed you examples from single institutions of quality improvement projects, but in the last 30 years, there have been many quality improvement collaboratives, starting with the Northern New England Cardiovascular Study Group. That was the first QI collaborative ever conducted and published. through the IHI's Breakthrough Series and the Vermont Oxford Network's NICU series of collaboratives. And most recently, a lot of states, many of them supported by the CDC's grants, have launched statewide collaboratives of NICUs, and many of them are tackling nutrition as one of their goals. Here's a nice toolkit from the California Perinatal Quality Care Collaborative. And Dr. Lee and colleagues published this nice paper on how they increased breast milk use in very low birth weight infants across multiple NICUs in California. This was the change package they used: education, focusing on maternal milk supply and establishing it, monitoring of nutrition, standardized regimens, supporting transition to breastfeeding. And in their project, there was a significant increase in the percentage of breast milk feeding at discharge to home. And also, importantly, a decrease in the percentage of babies who developed NEC that was sustained past the end of the project. This is an example of a project from California called the Mother's Own Milk Initiative. This has been ended. And they had improvement in some of the metrics that they targeted. So again, another example of a statewide collaborative. I have been working with the American Academy of Pediatrics on an online quality improvement platform called Equip. And I think this is the future of quality improvement. I think the days where teams travel to a location and meet face-to-face and spend thousands of dollars on a QI collaborative is going to be outdated pretty quickly, and already life has moved online. So programs like this, I think, will have a lot of potential to be applied. And in Equip, we have one module on GE reflux disease, not for neonates, but for patients of all age groups, including neonates. So if you wanted to improve value in neonatal nutrition, here are some potential approaches. You can try standardized TPN programs and see if they achieve equally good outcomes with a decrease in effort and resources. I showed you examples of Q-based feedings. We could try quality improvement projects where we do fewer lab tests and imaging studies. We could try projects where we have better selection of fortifier derived from human milk and appropriate use of this expensive product. We could increase the supply of mother's own milk and reduce donor milk use. We could prevent errors of nutritional product composition and administration, including TPN. There are published articles, and you can review them in that collection that I have a link to, which targeted the prevention of NEC, and many of them were successful. Preventing CLABSIs, I think, will also indirectly improve nutritional outcomes. And then I think we have a lot of work to do about transitioning to home nutrition and prevention of readmissions. So I mentioned inconsistency of care and variability. I think all of us should really strongly, if you don't already have them, develop unit-based guidelines, which are evidence-based. And when evidence is low quality or absent, perhaps we should try for something that I call consistent arbitrariness, where you kind of develop a consensus-based approach to providing care. Although there are some risks, because ideally you want the ideal practice like a target with consistent care by all professionals on target. But if you standardize care and everybody practices the same way, but you're off target for the patient's benefit, then you're not really helping the patient. You have a highly consistent practice that is not benefiting patients. But this is the current state of affairs where every clinician is practicing in his or her own way. And that to me is not acceptable. So in general, my personal feeling is some consistency and consensus-based guidelines are beneficial when evidence is absent or of low quality. And certainly there is justification from observational studies. This is a systematic review by Giussani and Patole, which updates a prior systematic review from these authors, which shows that when standardized feeding regimens were used, there was a reduction in NEC. And a couple of additional papers have been published after this systematic review was published, showing the same thing. There is really room for celebration and encouragement. I think with the intense focus on quality improvement in neonatology for over the last 25 years, there has been a reduction in the rate of necrotizing enterocolitis. These are data from the Vermont Oxford network from, I think, 650 NICUs, which shows that from 2005 to 2014, the rate of NEC has really come down. But it also shows that there is a significant room for improvement, with some units having a NEC rate of almost 7% or higher, and 25% of units having an NEC rate of 4% or 3.5% or lower. So finally, I want to end by introducing one important concept called co-production. This is going to be the next hot topic in quality improvement for the next 20 years. And this is an approach which is based on the belief that health is really not purely a product of the healthcare system, but it's a product of the patient and the family working together with health professionals and the healthcare system to ultimately improve outcomes and care. And there are many models where if you look at the green, which represents the contribution of the family and patients, and the blue, which represents the contribution of the healthcare system, there are many models by which the patient/family and the healthcare system can interact to ultimately produce outcomes. So these are the references. Let me stop here and answer questions. Thank you for your attention.
Thank you, Dr. Gautham. If you could then stop sharing your screen and go on video, we will get started with some questions.
Thank you.
All right, great. Thank you so much. That was a wonderful presentation. We definitely have some questions here. So let's start with, how do you resolve major differences in treatment approaches between neonatologists?
Thank you for that question. It's a very important topic that I've alluded to many times in my talk. What we do in our unit is we first do a comprehensive review of the evidence and summarize it in a way that everybody can look at it and weigh in on their own interpretation of the evidence. Then we draft a guideline on how we will apply that evidence in our own unit in practice. And then we go through a consensus building process where there is sometimes heated argument and disagreement. And somehow we come up with a consensus on how we will all practice. We always say that we want the clinicians to follow the guideline about 80% of the time, not 100% of the time. We want them to have some autonomy in making decisions at the bedside. And this has worked fairly well for us, though not 100% of the time. The challenge comes up when there is lack of evidence to really guide you in a specific direction. And that's where the discussion and opinions can diverge widely. And again, you have to have a good group facilitation process that will lead to consensus.
Okay, thank you. Next question, what is the ideal group number to complete a QI project? Also, what specialties do you need to complete a QI project, such as statistician, group leader, etc.?
I would say the ideal team size is about 5 to 6 people, and you should make sure to include people from disciplines that are really important to your project. And you're very right that there has to be one person in charge of collecting and organizing and analyzing the data. So that's one of the most crucial parts of any quality improvement project. So having one data person is important. Having a family representative is really important. And then you should have, of course, if you're doing a nutritional QI project, you should have a dietitian on the team. And then you should have other members based on the exact project and what needs to be done.
Okay, great, thank you. Next question is, how do you incorporate the views of neonatal dietitians who often have more nutrition knowledge than neonatologists, but have significantly less authority in the decision-making process?
Great question. I usually defer to them when I'm a clinician at the bedside. But in general, in the unit, I think dietitians have to be empowered and respected for their opinions and the knowledge that they bring to the table. And you don't want the clinician's knowledge to be completely suppressed or become atrophic from lack of use. So I think the dietitians should serve more as a coach and teachers rather than somebody who's telling people it's time to start the multivitamins or it's time to increase the protein. There's like a primary or a fundamental amount of knowledge and ownership that the primary team should take care of. Then the dietitian should be monitoring, coaching, guiding, and intervening in challenging situations. And that way clinicians feel that their autonomy is still being respected and the expertise of the dietitians is still being valued and incorporated. That's what I would suggest.
Great, thank you. Next question. At what gestational or birth weight do you consider exclusive human milk-based diet with human milk-based fortifier is essential and should be considered standard of care?
I think that's too specific a question. And what you can do is you can download our guidelines, the Baylor College of Medicine guidelines from the Baylor College of Medicine website, and look at the evidence and have a discussion in your own unit about what's right for your own unit. There is a nice commentary by Keith Barrington on his blog, neonatalresearch.org. And there is a new systematic review by Quigley and colleagues that was published in Archives of Disease in Childhood. And Dr. Prem Kumar, Dr. Pami and I wrote a Cochrane review on this topic. So I think you need a more holistic approach to a decision. And I don't want to give you a black and white decision now, especially considering that I'm not a primary researcher in nutrition.
Great, thank you. Next question. Human milk fortifier adds significant cost to the NICU operating budget. Can you comment on what you consider a reasonable approach?
The answer to that is the same as my previous answer. I think you have to consider the costs, your own NEC rates in your unit, have a local consensus, review the evidence, and then decide what works best for your own unit.
Okay. Next question. Do you believe that parental involvement, including provision of breast milk, improves with back transport of neonates to peripheral NICUs close to their residence and should be promoted?
Absolutely. I think it's one of the most important variables, especially as the baby gets closer to home and they start PO feeding and Q-based feedings. Having the parents, live close to the hospital where the baby is, so that the mom can go frequently and directly breastfeed the baby and bond with the baby is very, very important. Unfortunately, there are a lot of insurance barriers to back transport. And we in our hospital have struggled with that because the insurance companies often refuse to pay for ongoing care when you transfer down the level of care. So that's been a challenge.
All right. Next question. What should be the structure of a central QI committee?
I'm not sure of the exact definition of a central QI committee, but if you're talking about a QI committee that oversees all the quality improvement projects in a NICU, I would say we should have the physician leaders, the nurse leaders, respiratory leaders, and other leaders from other disciplines like social work, dietary, care coordination. So in our unit, we have an interprofessional leadership committee that meets to review all these. And you should have a QAPI program, a quality assessment and performance improvement program, which actually in Texas is mandated by the designation rules. And this should be the committee that reviews the quality dashboard. In our unit, we do it once a month. And it allocates and resources quality improvement projects and has the teams report back at the QAPI meeting once a month on their progress. So that's one potential way of organizing a central QI committee.
Okay. And we'll do one more question. Many of the mothers in our patient population choose not to pump breast milk, and we do not have access to donor milk. This will artificially lower our percentage of breast milk at discharge. How do we deal with this problem?
Yes, that's an important kind of a correction that you have to apply, because ideally you should be measuring the use of breast milk either during the hospital course or at discharge, with the denominator including only the mothers who intend to provide breast milk, their own milk. So if the metric is tracking mother's own milk, the denominator should ideally include only mothers who intend to pump and should eliminate mothers who refuse or do not have any desire to pump. That's one way I would do it. But all these general databases just collect breast milk at discharge, and in some areas of the country where a high percentage of moms choose not to pump or provide breast milk, the NICUs can appear worse than they actually are.
All right, great. I want to thank you so much, Dr. Gautham, for your time and sharing your insights. Thank you, everyone, for joining us. We hope that you join us at our next webinar on October 27th. So watch for that invitation coming in your inbox. Take care, everybody.
Thank you so much. Thank you for your attention.
Bye-bye.